Welcome to this event, which is the first of a series focused on hypertension. In this program, we'll focus on the diagnosis of hypertension based on the latest NICE guidance. We know that 1 in 4 adults in England have high blood pressure. Hypertension is 30% more common in areas of deprivation. If we look at premature deaths, high blood pressure is the third biggest risk factor for deaths and disability after smoking and poor diet. We also know that 50% of heart attacks and strokes are associated with high blood pressure, and this is also a major risk factor for patients with chronic kidney disease, heart failure, and dementia. The rule of halves suggests that half the people with high blood pressure are not known. Half of those who are known are not treated, and half of those that are treated are not controlled. So if we had 200 people, we know 100 would be known to be hypertensive. Of those, only 50 would be treated, and of those on treatment, only 25 would be controlled. So of a population of 200 hypertensive patients, only 25 would have adequate control. What is considered a normal blood pressure? Well, a blood pressure is seen as normal if it's 140/90 or below in a person aged 80 or less, or 150/90 or less in a person who's aged 80 or more. Please remember, this is in the clinic situation. For an ambulatory blood pressure monitor or a home blood pressure monitor, then we'd be looking for a normal level of being 135/85 or less. Also, please note there are certain chronic diseases where we may be looking for blood pressures lower than the normal blood pressure we'd indicated above. So, for example, in diabetes, for most patients, we'd be looking at blood pressures of 135/85 or less in a clinic situation. You're in your surgery and you take a blood pressure on a person who's not known to be hypertensive, and you find it's between 140/90 and 180/110, you might think, is this person hypertensive? But before you confirm the diagnosis, you should arrange an ambulatory blood pressure monitor, or if this isn't available or declined, then think about doing home blood pressure monitoring. If the blood pressure is greater than or equal to 180/110, you should consider referring this to the duty doctor, as this patient may need some urgent intervention. You've arranged for this person to have some further blood pressure measurements. Whilst waiting to confirm the diagnosis of hypertension, you should arrange some investigations to look for target organ damage and also assess their cardiovascular risk. The recommended investigations to look for target organ damage are as follows. Looking at the urine, you should arrange for an albumin-creatinine ratio. You should dip the urine and look for hematuria. You should arrange some blood tests, which includes U's and E's, an EGFR, cholesterol, HDL, and hemoglobin A1C. You should also look in the eyes to check for retinopathy and also arrange a 12-lead ECG. If a person is found to be hypertensive, it's important that you estimate their cardiovascular risk to help you decide on what the most appropriate treatment going forward is, particularly if you need to consider primary prevention. You should do a full cholesterol screen, which includes a total cholesterol, HDL, cholesterol, non-HDL, and triglyceride. This sample does not need to be fasting. It's important to think about familial hypercholesterolemia, and this should be considered if the total cholesterol is greater than 7.5 millimoles per litre, and there is a strong family history of premature heart disease. Why is familial hypercholesterolemia so important? Well, it's not a rare disease. It occurs in about 1 in 250 people in the population. And those people will have a lifetime exposure to higher than normal levels of low-density lipoprotein, which could precipitate an early presentation of coronary heart disease. It's important to notice that over the last 30 years, the management of high cholesterol has improved significantly with the introduction of drugs such as statins and ezetimibe, and also the newer drugs such as the PC5K9 inhibitors, all of which have made a real difference. For ambulatory blood pressure monitoring, the machines will measure 2 blood pressures per hour, and you need to use an average of at least 14 measurements spaced over a number of days. Most machines will produce this figure automatically. If you're going to diagnose hypertension using home blood pressure monitoring, ask the patient to take their blood pressure when they're sitting for 5 minutes and then to take 2 measurements at least 1 minute apart. They should do tests morning and afternoon for 4 and preferably 7 days. When you get the results, you should discard the first day and use an average of all the other readings to diagnose hypertension. What to do next? If there's evidence of target organ damage, then start the antihypertensives immediately. If no evidence of target organ damage, then repeat the blood pressure in the clinic in 7 days' time. So in summary, if the clinic blood pressure is between 140/90 and 179/119, arrange for an ambulatory blood pressure monitoring, or if this is declined or not available, arrange for home blood pressure monitoring for a minimum of 7 days. Investigate the patient for target organ damage and also assess their cardiovascular risk and arrange a follow-up appointment. So finally, stage 1 hypertension is defined as a clinic blood pressure of between 140/90 and 159/99, or looking at an ambulatory blood pressure monitor or a home blood pressure monitor between 135/85 and 149/94. Stage 2 is when the clinic blood pressure is between 160/100 and 179/119, or an ambulatory blood pressure monitor or home blood pressure monitoring between 150/95 or higher. Stage 3 hypertension or severe hypertension is when the clinic blood pressure is 180/120 or higher. Many thanks for listening to this program. I hope you found it interesting and informative. In our next program, we'll cover the management and treatment of hypertension.